Dharmaraj, it's time.
Greetings and welcome everyone. As a monthly initiative, Student Council 2021 is organizing an online continuous medical education talk for the greater benefits of Manipal University College Malaysia students under guidance of our Student Council advisor, Prof. Dr. Som Subrade. First and foremost, I would like to welcome Prof. Dr. Adi Negara, Dean of Faculty of Medicine, Prof. Nachi Apan, Prof. Dato Jaswan Singh, Prof. Samira, and Prof. Dr. Som Subrade for gracing us with their presence today. Before we start, I would like to announce some ground rules for the CME talk. Please keep all your mobile devices on silent mode. Please refrain from eating in front of the webcam. Please ensure that you are dressed appropriately. Throughout the talk, your microphone will be muted by the host and the co-host of the meeting. Please turn on your video to engage and interact with the speaker during the Q&A session. This meeting will be recorded and pictures will be taken for documentation purposes. By attending this meeting, you have given your consent for the recording and picture taking. We will now proceed with the picture taking session. All the participants are required to turn on your camera.
Good evening, everybody. Please turn on your webcam. This is just for the photography session. After that, you can off the camera and be more relaxed. I would like to welcome Prof. Adi, Prof. Nachi, Prof. Samira, Prof. Dato Jaswant once again. We'll take another 1 or 2 minutes to ensure that everyone's on their camera. This would also ensure what Dharmaraj said, that all of you are dressed appropriately for the session. Okay. I see quite a few people not on your camera as yet, so I'll give another 30 seconds. Just quickly on your camera, we take the picture, otherwise the picture will have only your names and not your face. Normally we have a session where we have face-to-face, where people come and sit together and we take pictures, but here, this is the max picture we can do. You can always give a nice big smile when we are taking the picture. There's 78 of us at the moment. We're expecting 100 people are coming in. Right, so now that majority has on the camera, now you can strike a pose or a thumbs up, like preferably a thumbs up, and or some other pose. Okay, in 3, 2, 1. This is for page 1. We have 2 pages, so hold on. You might come in both pages or you might come in one page. So once again, hold on your pose in 3, 2, 1. Yes, Dharmaraj, pictures taken. Back to you.
Thank you, sir. Now, I would like to invite the Dean of Faculty of Medicine, Prof. Dr. Adi Negara, to welcome our speaker.
All right. Thank you, Dharmaraj. Can you all hear me?
Yes, sir.
Yes, can.
So good afternoon. Prof. Nachepan, Director and Head of Department Surgery, Prof. Samira, Head of Department ONG, Prof. Som Subrade, the Student Advisor for the Triple MC, or now Manipal University College Malaysia, and Dato Jaswan, Prof. Dato Jaswan, and of course, beloved students, and of course, now we have the VIP guest of honor, Dr. Neo Regan. Thank you so much for being in this session. All right, so on behalf of Prof. Jaspa Singh, the Vice Chancellor of Manipal University College Malaysia, all right, you heard me right. Manipal University College Malaysia. We welcome you to this session, a CME talk by Dr. Neo Rejan, one of our alumni from batch 19. So for that, I take this opportunity to thank the Students' Council. The Students' Council under Praveen, Roshni, and I think today we have the co-hosts, Talmaraj, Barsha, Kanchana, and the rest. They have been very much active in initiating these programs under the steward facilitation of Prof. Som Subrade. A round of applause to Prof. Som Subra. He has been our advisor from the day one of this institution with regards to the Students' Council. I think Dr. Neo, are you with me, Dr. Neo?
Yeah, I'm with you.
Can you remember your being the Students' Council? I think Prof. Som Subra was likely the student advisor at the time, the advisor for the Students' Council during our time. So, so Prof. Som, thank you so much. And just to inform all, this has been a regular event. So we really applaud the activities done by the Student Council. And just for your information, we have had sessions on radiology, which was the first with regards to the subspecialty on radiology. That was about a few weeks back. And before that, we had on public health. And before that, we have numerous subspecialties. And we would like to keep the flag flying, all right, with regards to Manipal logo. Just to inform all, when I say that most of the specialists in the country are from Manipal emblem, I meant it, all right. And just inform that we would like to see all of you, being like Dr. Neos and so on. And I would like also to encourage students, especially, try to download this Telegram. You don't have it in your mobile. This Telegram application, go to the Manipal alumni, and every Monday there will be a motivational Monday by specialists hailing from the Manipal group, from Melaka Manipal Medical College, or from the fraternity. We have now reached 140, and these are those who have actually gone into the motivational Mondays, and there are numerous others who do not want to come in. They're feeling shy and so on. So 140, Dr. Navin Kumar, pediatrics. Then Dr. Kantarao last week was he has just completed his MRCP and so on. So we have whole list of specialists, coming out from this Manipal group. And we want all of you students, please, continue, keep the flag flying of Manipal. And talking about Manipal, we are in this event of COVID pandemic. The last 13 months to be exact. The first cases in Malaysia was noted on 25th of January. Now it's 25th February, 25th of January last year. So 13 months to be exact to the first cases. And all the time we have had bad news, with regards to, MCO, the restriction of activities and so on. But the good news hailing from, the activities from last year and just announced 2 weeks ago, we were conferred the level of university college. So a round of applause to the institution. So we are now declared as University College level, Manipal University College Malaysia, and would like to congratulate the team, and especially Professor Dr. Jaspal Singh for having the momentum to reach this level. It's not easy, I tell you. So we hope to reach the university level the next 5 years. So just to keep yourself, you don't hear it from me. Just to inform you, when we reach the university level, it'll be something unique to us. We might be even called MUM, M-U-M, Manipal University Malaysia. So that will be another 5 years down the road. Okay, so we'll be the only MUM amongst all the universities. All right. So coming back to this CME talk, so Dr. Neo, thank you so much for having made your way here. All right, though usually we have a face-to-face interaction, the speakers would come in, but this is a COVID-19 pandemic, so we do as best as possible virtually. So Dr. Neo, he has completed his MRCP, and he shall be finishing his neurology in just 1 or 2 years, so he's towards the end. So I think afterwards, Dr. Neo would be telling us on how to navigate through neurology. But as I've mentioned just now, it's not just about neurology, it could be anything. This when he tells us about his journey. So whatever that you have in mind, just make yourself into that position, and gear yourself to and gaining that subspecialty or specialty. So again, on behalf of the institution, we'd like to thank the the speaker, Dr. Neo Rejan, for having made your way here and sharing your thoughts, all right, and expertise and wisdom. So I'd like to thank the Students' Council, especially Prof. Som Subra. I would like to thank all of you to be here. So thank you so much. So over to the MC of today. Thank you so much.
Thank you, Prof. Dr. Adi Nagara. Now I would like to invite Ms. Sumitra to give a brief introduction of our speaker of the day.
Thank you, Dharma. Now I would like to introduce our guest speaker of the day, Dr. Neo Rejan, one of our very own college alumnus of Bachelor of Medicine and Bachelor of Surgery, MBBS, Batch 19, in the year 2011. He then pursued his specialty certificate examination in neurology from the Royal Colleges of Physicians of the United Kingdom and the Association of British Neurologists in the year 2018. His work experiences include serving as a house officer in Hospital Miri, Sarawak from the year 2011 to 2013. He then became a medical officer in internal medicine, nephrology, neurology, dermatology, and hematology in the span of 2013 to 2016 at the same hospital. From 2016 up to 2019, he was a clinical specialist of internal medicine and rotation in cardiology and endocrinology in Hospital Selayang. Currently, he is a neurology registrar in neurology department with special interest in movement disorders at Hospital Kuala Lumpur. His amazing achievements include Anugerah Perkhidmatan Cemerlang in the year 2017, organized MRCP examinations in Hospital Selayang in 2017 all the way to 2019. He was a provider for Advanced Life Support, ALS, in the year 2017, a committee member in Annual Scientific Congress Acute Medicine in 2016. He was an invited speaker for National ELASMED, Medical Updates, Dengue Updates, Clinical Research Center, New Recruits Training, and House Officers Orientation on Patient Safety Goal and Antimicrobial Resistance. He has also successfully published a case report in Medical Journal of Malaysia regarding Japanese encephalitis, presenting with cerebral venous sinus thrombosis. He holds membership in Malaysian Medical Association and member of Royal Colleges of Physicians. So without further ado, let's invite Dr. Neo Rejan to begin his talk.
Thank you, Sumitra, for the kind introduction. Good evening, Prof. Adi, Prof. Dato' Jaswan, Prof. Som, Prof. Sumitra, Prof. Nachi, and all the faculty members who are present today, and all the participants here. It's always a great honor to be able to give back to your alma maters. I would like to share my screen here. So thank you to Prof. Som and Student Council for the arrangement and invitation for this talk. So my talk will be divided to two parts. So first is about neurology training in Malaysia, and then the second part is about Parkinson's disease. So currently I'm the second year neurology trainee. I'm from batch 19. I'm already moved to Penang now. I'm working in Penang now because we have a rotation during our subspecialty training. So I managed to dig out some old photo here. The MV, and then here Prof. Nishi, and here Prof. Jaspa. At the time he was a head of department for ENT department. And this Prof. Uduman, he has left and currently working in Pantai Hospital, Pantai Melaka. He's a neurologist, the only neurologist in Melaka at that time. So during my final year in medical school, I always sleep to join his clinic in Hospital Melaka to learn about neurology. So I learned tremendously from him. He's a very jovial and kind person. So this is the photo of the first neurobike in 2011. So the team is here. This is Dr. Som, and this is my team. So we got the first place at the time. So I will share about the neurology training in Malaysia. So the initial period, after you pass your MBBS, you need to do the housemanship for 2 years. And then you need to be a medical officer in the internal medicine related department for 4 years. So related department means you can be rotated to various subspecialty like nephrology, neurology, endocrinology, but you cannot stay in that subspecialty forever. For example, you cannot stay in the derm for 2 years. So only 6 months will be counted as your training duration in the internal medicine. So you need to complete about 4 years. And during these 4 years, you can choose 2 pathways to become the physician. The first is the MRCP, and the second is the master program. So MRCP, we know they got 3 parts, part 1, part 2, and paces. It depends on how fast you can take it. Some people can finish in 1 year, but most commonly in 2 to 3 years. And or you can join the master program under, like, for example, UKM, USM, or UPM. There will be 4 years program there. Normally 2 years off campus, 2 years in campus. You will also be rotated to various subspecialty training. And at the end, after you completed 4 years, for example, you have passed your MRCP within these 4 years, you have completed 4 years in the internal medicine, you will be doing your gazettement for 6 months as a physician. So I would like to say this catchy phrase, but during my time, I only need to complete for 3 years. Then after that, I become a physician for 18 months. So now they only want the physician to be gazetted for only 6 months. So it's a bit shorter now. And you need to complete your physician work at least 2 years before you can apply for your subspecialty. This 2 years is counted from the beginning of your gazettement. So for example, you have finished 4 years here. You start your physician gazettement. The date that you start your gazettement, 2 years from that, before you can start applying for your subspecialty application. So total is about 8 years. This is true for all the internal medicine related subspecialty, like if you want to be a cardiologist or endocrinologist, so it's the same. Now I go to the neurology subspecialty training. It's a 3 years program, 2 years local and 1 year overseas. Many people don't know, but actually we have many training centers in Malaysia. So people always thought it's only in KL or Penang, but actually we have HKL, Hospital Sungai Buloh, UKM and UMMC in Klang Valley. At the North region, we have Hospital Pulau Pinang, Hospital Seberang Jaya, in Terengganu or USM. And in South, we have JB. And in Borneo, we have Queen Elizabeth and Sarawak General Hospital. I believe in future, there will be more training center, because in order to be qualified as a trainer, you only need to work for 2 years as a neurologist. So I believe more and more center will be opened up so we can train more neurologists in the future. And during the 3rd year, during your 1 year overseas, you can actually choose your special interest. So I will talk more about special interest later. And at the end of the 3 years, you will have an exit viva, in which there will be 3 assessors, 1 from Ministry of Health and 2 from the university. And if you pass, the bonding period with the government after completion is 6 years. But if you wish to quit the government service, you will need to pay the payment because this neurology subspecialty training is actually a scholarship program under Hadiah Latihan Persekutuan. So this is a timeline to show you the pathway to become the neurologist. So normally we start taking our MBBS at 20 years old. Some may be earlier if you take a shorter pre-U program. So you completed your MBBS 5 years program, you will graduate at 25 years old. After that, complete your housemanship, 27 years old. So you will become the medical officer for 4 years. So during this period, you will start taking your MRCP or Master of Medicine. So you will be at 31 years old now, doing your gazettement, doing your physician work for 2 years. Then you will start your neurology fellowship training at 33 years old. So by the time you finish, you will be 36 years old. So that will be my age next year. I will finish my training next year. So what are the content of the neurology training? So during the neurology training, you will be expected to learn how to take a neurological history taking. For example, let's say you have the patient have a headache. So it's a similar thing that you learn in medical school. So there's a site of headache, what's the onset, the duration, the progression, what's the aggravating and relieving factors, what's the nature of the pain, what is the severity of the pain, and any associated symptom. And from there, you do a targeted physical examination. You will be learning how to do the cranial nerve examination, upper limb, lower limbs, and some special tests, and come up with a diagnosis. So you will hone your skill during the neurology training, and of course, throughout your life. So other than that, you will also be doing the nerve conduction study. So in this diagram, I just show an example of nerve conduction study of the median nerve. So the stimulator is at the median nerve at the wrist, and we're recording the abductor pollicis brevis muscle. So after the electrical stimulation, you will get a graph where you can see that it will be measuring the distal latency, the amplitude, the conduction velocity. And from that value, you also do together with all other nerve, lower limb, sometimes the face, and we come to some important clue regarding the patient peripheral nervous system. You also can supplement the NCS with electromyography or EMG, where you can insert this very thin needle into the muscle. For example, you can insert a needle into the APB here, and you can see for any spontaneous activity or the motor unit action potential. You will also be learning about electroencephalography or EEG. I will show some example later. This is equivalent of ECG of the brain. So you are recording the electrical activity of the brain, which can actually reveal so much information. More commonly, we will be want to look for the seizure, the location, any syndrome or some encephalopathy. There will be you will also be learning how to do an evoked potential study. So VEP stands for visual evoked potential, somatosensory evoked potential, and brainstem auditory evoked potential. So you will be studying the visual pathway. So if there's any abnormality in the visual pathway, there will be abnormal in the electrical response, which you can interpret, and will come with the good information that can help your patient. So you will be also learning on how to interpret the neuroimaging, usually the CT brain, MRI brain, and MRI spine. So a lot of time we don't depend on the radiologist to give us the reporting, because sometimes the radiologist also can miss certain part of the neuroimaging. Neuroimaging has become very subspecialized that we also have neuroradiologists. So usually the neurologists would like to see the scan themselves and interpret the scan themselves. So we also learn how to inject the botulinum toxin, usually for the indication of like hemifacial spasm, blepharospasm, spasticity, dystonia. So not just the aesthetic doctor who operate the clinic from the sky of KL. So the neurologist also can inject the botulinum toxin. So over the years, the stroke thrombolysis has become more famous. So last week, I encountered an old lady, 81 years old, who presented with left MCA stroke. She got the right hemiplegia. She has a global aphasia and the right homonymous hemianopia. So we call that right total anterior circulation infarct. So we did the CT scan. She came early, very luckily, at 1 hour of onset. So the CT scan is fairly early, stroke changes. So we give the thrombolysis, and I myself administer the thrombolysis. So at the end of the 1 minute of the thrombolysis, the patient look at me and start mumbling and move her right hand. So it's very rewarding to see the instantaneous recovery of the stroke symptom after you give the thrombolysis. And of course, we have been privileged to certify the brain death. So the common scenario is the patient, there may be an accident, the patient may have a traumatic brain injury. Despite the treatment given, there is no meaningful recovery and there's sign of brainstem death. So the neurologist and the anesthesiologist usually will be called to certify the brain death. So we will be testing the brainstem reflex, and together with the apnea test, we will come up with a conclusion whether the patient has brainstem death or not. So from there, they may consider to proceed with the organ donation if it's suitable. So these three other procedure that is not famous yet. It's still optional, but I believe in future they will become more common. We have a transcranial Doppler to study the vessel in the brain, whether it's any stenosis or thrombosis, and transmagnetic stimulation of the brain, which can be useful for diagnostic and therapeutic purpose. It can even treat migraine and neuromuscular ultrasonography. So we can check for the evidence of neuritis or myositis from the ultrasound. So this is an example of the EEG reading. So the even number on the left here is the right side. The odd number is the left side. So you can see that there's some wave here. This is called alpha rhythm. It's around 8 to 13 hertz. It's normal, relaxed alertness. And beta rhythm is more than 14 when you are thinking or doing some activities. So this is an example of the typical 3 hertz spike and wave discharges seen in absence seizure. So about neurology special interests, we have many, but the one on the left side here are the one that is commonly chosen by our neurology trainee. So for example, stroke specialists, so they will be dealing with stroke, because stroke has become very much more complicated. You will be learning about interpretation of CT perfusion, MR perfusion, MR vessel imaging, and some difficult stroke syndrome. So definitely we need more stroke specialists because it's a very demanding service, and it's also one of the most common presentation into the neurology department, the stroke. And there's epilepsy. So we study epilepsy, become the epileptologist. So nowadays, the one that we are famous is that we are preparing and work up the patient for the epilepsy surgery. For example, if the patient have the temporal lobe epilepsy. So the temporal epilepsy is usually caused by the mesial temporal sclerosis. There's a scar in the hippocampus part of the temporal lobe in the brain. So in the EEG, you may see a spike and wave at the temporal region. So this type of epilepsy, temporal epilepsy, is very amenable for epilepsy surgery with the 70 to 80% cure rate. So it's very rewarding also to treat temporal epilepsy with epilepsy surgery. Not just temporal epilepsy, there are other epilepsy as well, like focal cortical dysplasia or any tumor or any AV malformation that may cause a seizure. Once removed, it will greatly help the seizure control. So we also have the neuromuscular. Like the name mentioned, there are two parts. One is a nerve part, one is a muscle part. So the nerve part can be peripheral neuropathy, the Guillain-Barré syndrome, CIDP, and the muscle part can be your muscular dystrophy, limb girdle muscular dystrophy, the myositis, dermatomyositis. So the fourth is the movement disorders. So this is my passion. I'm interested in the movement disorder. So movement disorder actually concerned with people who move very little or move too much. So move very little normally is Parkinsonism, or move too much is like chorea, tremor, myoclonus, dystonia, tics disorder, hemibalismus. So the movement disorder specialist will be treating this disorder. And over the years, there's a recent increase in the number of the neuroimmunology trainee because it has become more famous. Neuroimmunology actually deal with, for example, the autoimmune encephalitis, like anti-NMDA encephalitis. And over the years, more and more antibody has been discovered. And of course, also include the demyelinating disorder, like multiple sclerosis, NMOSD, anti-MOG. So definitely we need more specialists in this field because there's an explosion of knowledge in that field that even we find it hard to cope up with the knowledge explosion. So on the right side here is less common, like we only got one headache specialist in Malaysia, one sleep specialist in Malaysia. The rest, actually, we don't have any neurologists in this special interest in Malaysia. So we just talk about why we choose neurology. Yeah? So why should you choose neurology? You must like to learn the subject. So you like to learn about the neuroanatomy, you like to deal with patients with stroke, seizure, movement disorder, nerve and muscle problem. I cannot imagine if you don't like to learn the subject, but you take the specialty, how will you force yourself to read the book and to read the articles regarding the subject? So if you love the subject, that's already half journey done. So first, you must like to learn the subject, you like to treat the headache. And second, the neurology is still very much clinical. You still need to use your tendon hammer, the orange stick, the fundoscope, the pen torch to localize the lesion and come up with a possible pathology. So if you are a person, you want to be the doctor who are very much clinical, to use your skill to pick up the sign and come to the diagnosis, neurology can be for you. So build up from the second point, I believe you won't be replaced by autonomous in AI yet lah, AI. So over the years, we have interest and resurgence of this AI fear that AI is going to replace our occupation. Apparently in 10 years time, they are going 40% of the job will be replaced by AI. But I believe neurology won't be replaced by AI so fast yet. It's because one of the most important component of the AI is the data. So if the AI will only function well if you give them a good data. So if you give them a bad data, they will give you the wrong diagnosis. So from the emergency department or even the medical department itself, they are not able to get proper history or able to elicit the proper neurological sign to come up with a diagnosis. So can you imagine if you don't get the proper sign, you may miss the diagnosis. But if you are only feeding this wrong data into the AI, then you make it the wrong diagnosis. So I believe we still need neurologists to get the proper sign and history, and only then we can get the proper diagnosis. So I believe the neurologists will be working together with AI in the future to come up with a better and more precise treatment for the patient. It's a growing specialty as well. So last time people used to tell me, don't take neuro because you cannot do anything anyway. Patient will be paralyzed. Have the resurgence of all the new treatment over the years. You can see this part of the imaging. This is a patient who came with stroke in UKM where I was trained last year. So in this, we have the MCA occlusion over, this is from the front coronal view, and this from sagittal. There's the MCA occlusion. Then we push the patient for the mechanical thrombectomy. The IR did the removal of the clot with stent retrieval, and you can see a beautiful firework. The vessel reperfused, so it supply back the MCA and the ACA part of the brain. And this is a sagittal view, very nice. And the patient had good recovery. So mechanical thrombectomy is gaining more interest, gaining more traction. So more and more interventional radiologists want to do stroke thrombectomy service, and
Neo, I think you got disconnected. Maybe you have to start sharing again.
yeah, wait, did I stop just now? Did I stop around here?
A bit before you can start.
Okay, continue. So you can see this part, discovery. There's so little drug that we have discovered, but over the past 40 years, there's so many new anti-epileptic AED that has been discovered. So definitely there are more and more better treatment, more personal treatment for the patient. And finally, there's a high demand for the neurologists. So if you can follow this Japanese concept of ikigai, where to choose your calling, you need to have what you love, what you're good at, what you can be paid for, and what the world needs. The world definitely needs neurologists. If you can see in this part, this is published in Lancet in 2019 by Prof. Lim from show that the Malaysia, who have a 32 million population, has only 102 neurologists. So one neurologist have to treat 314,000 individual in the population. So we are only better than Laos and Cambodia. So if you can see a better country like Japan, one neurologist will treat 21,000, and our nearest neighbor, one neurologist will treat 58,000 individual in the population. And this is so I finished my first part of treatment. So when we asked the student council to select the topic, the student actually choose 4 topics for me: the dementia, Alzheimer, epilepsy, and Parkinson. So I have no doubt I choose Parkinson because this is my interest. So due to the interest of time, I may need to speed up. I may not present all. So it was first described by James Parkinson in 1917 in his paper on the shaking palsy. So the pathogenesis was believed to be the interaction between the genetic and environment. It's an alpha synucleinopathy. If you see the diagram on the right, there's an alpha synuclein monomer in the normal state, but in the pathological state, they start to aggregate to become an oligomers, and they become a fibril. Fibrils will start to also aggregate and become a Lewy body-like inclusion, and it may cause dopamine neuron death and apoptosis. So the Parkinson disease is characterized by loss of dopaminergic neurons in the striatonigral pathway. So this is substantial nigra, normally it's pigmented, but in the Parkinson disease patient, there's loss of this pigmented cell. So Parkinsonism is a blanket term for a patient who present with this bradykinesia, tremor, and rigidity. But Parkinson disease is not the only diagnosis when you have seen a patient with Parkinsonism. It's a primary and secondary cause as well. So in PD, this is an idiopathic Parkinson disease. So it means if you fulfill there's no other red flag, no other exclusion criteria, so the patient can be diagnosed as Parkinson disease. But sometimes patient may have some atypical feature. So you may think that they may have some Parkinson plus syndrome, like multiple system atrophy, progressive supranuclear palsy, cortical basal degeneration, or dementia with Lewy body. There are many other parts of genetically inherited Parkinsonism, and secondary causes are important because some are very much treatable. So it's important to be thorough to get the history and examination to find some abnormal feature that may suggest secondary causes. For example, vascular causes like stroke, drug-induced like antipsychotic, antiemetic, metabolic, infectious, endocrine cause, autoimmune and paraneoplastic, some toxin or normal pressure hydrocephalus, which can be easily seen in the imaging. So this is a very nice paper of neurology in movement disorder in UMMC. He published in Lancet in 2019 about the prevalence of Parkinson disease in the Western Pacific region per 100,000 population. So if you can follow my pointer, I will just highlight a few. For example, in Taiwan, there's 130 per 100,000, China 31, Singapore, we have 80 per 100,000. Region with no published prevalence rate of the prevalence based on this GBD in 2017. So Malaysia is around 108 per 100,000 population. So we have the Movement Disorder Society, or MDS, clinical diagnostic criteria for the Parkinson disease. So from there, I will enumerate how to diagnose a Parkinson disease. The cardinal feature is these 3: a bradykinesia, which is defined as the slowness of the movement and also the decrement in the amplitude and speed. There may be hesitation and halt as the movement are continued. And there is also rigidity, where it's velocity independent, resistant to passive movement, and it's not due to failure to relax. And there will be rest tremor, which has been defined as the 4 to 6 Hertz oscillatory movement in the fully resting limb, which is suppressed during the movement initiation. So according to MDS, we have two types of diagnosis for PD. One is the clinically established, another clinically probable. So to diagnose and establish PD, we need to have an absence of the absolute exclusion criteria, 2 or more supportive criteria, and no red flags. For the probable PD, you may have some red flags, but it's counterbalanced by the supportive criteria, but not more than 2 red flags. I will just go briefly on this. The supportive criteria is a clear dramatic response to dopaminergic therapy like levodopa. There is a levodopa-induced dyskinesia. Because, for example, in the other disorder like MSA or PSP, they may not have a levodopa-induced dyskinesia. So levodopa-induced dyskinesia actually is a feature of Parkinson's disease. The patient have a rest tremor and olfactory loss on this MIBG scintigraphy, which we don't have in Malaysia. There are other green flags for PD. What are the features that may actually help you to think that this is actually an idiopathic Parkinson's disease? If the tremor is unilateral in onset, it's a resting tremor, usually pure rolling, upper limb more than lower limb, more than jaw. There's a limb bradykinesia. Usually one side will be much worse than the other side. The rigidity usually is also starting unilateral, only cause mild to moderate discomfort to the patient. And the gait and balance usually won't be very much affected until the late part of the disease. The progression is slow. There's a good response to levodopa with sustained peak benefit. The cognition is relatively preserved, and the impairment of the cognition is a late feature in the idiopathic Parkinson's disease. The patient may have autonomic symptoms, but usually it's mild to moderate, and it's a late feature if it's advanced. So if you have all these green flag feature, then you may actually diagnose PD clinically, even without any neuroimaging. Okay, I will talk about exclusion criteria. If you have any of these, you cannot diagnose Parkinson's disease. So if you have a cerebral dysfunction, you have vertical supranuclear gaze palsy, you have some feature of frontotemporal dementia, or your Parkinsonism is only restricted to the lower limb, such as, for example, in a vascular Parkinsonism, and patient was on anti-dopamine treatment, or any absence of the good response to the high dose levodopa. Or if there's any unequivocal cortical sensory loss, for example, in the cortical basal syndrome, or any normal DET scan or functional presynaptic dopaminergic system, which we don't have in Malaysia yet. So the red flags are many. I will just touch a bit. If you have an early gait impairment, you have an early bulbar dysfunction, you have inspiratory respiratory dysfunction, or some severe autonomic failure within 5 years of disease, recurrent fall, absent or no motor features after 5 years, and some pyramidal tract sign, you may think that patient may have other diagnoses, but even Parkinson's disease may have some of these features. So that's why you have a maximum of 2 red flags need to be counterbalanced by 2 supporting features to diagnose the probable Parkinson's disease. So I like to show this natural history of Parkinson's disease graph. It's a very beautiful graph. You can see here, the pre-motor stage, the patient may have a constipation. So it may predate the motor symptom of Parkinson's disease even 20 years before the symptom. And 10 years before the onset of motor symptom, the patient may have a REM sleep behavioral disorder. So what does this mean? During the REM sleep, we will have an active dreaming state. But normally our brain will tell our body to stop moving. We don't move or we don't talk during dreaming. But in Parkinson's disease, they have impaired mechanism for that. So they may act out their dream, they may talk during their dream, and this can be dangerous to their partner because they may be punching or kicking their partner. So the patient may also have excessive daytime somnolence. I think the student may be worried now because they may have excessive daytime somnolence during the lecture, but this is also one of the feature, non-motor feature for Parkinson's disease. They may also have hypoosmia. This feature has become famous recently because of the COVID-19 pandemic. and they may have depression as well. So the depression in Parkinson's disease is not due to, I have Parkinson's disease, so that's why I become depressed. Actually, it's not. The Parkinson's disease itself can cause some problem with the neurotransmitter, especially serotonin in the brainstem, so that will lead to the depression. So the depression is due to the disease. Then over the years, you start to develop motor symptom like the one that I say, tremor, rigidity, bradykinesia. And as the year progresses, you will have a more severe non-motor symptom. You can see from the beginning, the non-motor symptom increases, the motor symptom increases, and the complications start to arise. The complications include the fluctuation and dyskinesia and psychosis, which can also be due to Parkinson's disease, but can also be due to the treatment itself, like dopaminergic therapy. So the management, so we also need to talk about non-pharmacological management. So the nutrition is very important. We need to eat healthy because we have been found that the free radicals actually can accelerate the neurodegeneration of the brain. And there's a recent interest in the gut microbiota where they study that the Parkinson's disease patient and MSA patient actually has a different gut microbiota profile compared to the normal population. So caffeine and black tea has also been found to be protective for Parkinson's disease. So definitely we need to advise our patient on nutrition. Exercise is very helpful to prevent Parkinson and also improve the Parkinson UPDRS score. So the exercise include aerobic exercise, the strength training, or even Tai Chi. Tai Chi can, there's a study that studied Tai Chi in a Parkinson's disease patient that actually improve their UPDRS score and the gait. And the sleep is very important because when during the daytime, we have a lot of metabolite and toxin accumulate in our brain. And during sleep, these metabolites will be cleared off by the lymphatic system. So if you have an impaired sleep or dysfunctional sleep, then you may have this impaired clearance that will cause the metabolite to accumulate at the alpha-synuclein. So that may actually leads to a Parkinson's disease. So this is not only true for Parkinson, but also for other disorder like Alzheimer, where the tau protein can accumulate and causing Alzheimer. So other than that, we need to be socially well and psychologically happy. So this one diagram will summarize all the pharmacological treatment for Parkinson's disease. If you follow my pointer, so for the dopamine synthesis, it came from the amino acid tyrosine, where we converted to L-dopa. The L-dopa is a precursor for dopamine. The dopamine will be stored in the synaptic vesicle, which will be released into the synaptic junction, where we actually bind to the dopamine receptor and they will exert this function. So the dopamine will be reuptake back into the presynaptic neuron, so they can be reused back, and some of it will be degraded by the catechol-O-methyltransferase enzyme, or COM, or in the presynaptic neuron, we have a monoamine oxidase B enzyme, which will also degrade the dopamine into its metabolites. So the treatment for Parkinson's disease, we have a levodopa, which actually at this part, so we supply the precursor for the dopamine. So usually it's prescribed together with the peripheral decarboxylase inhibitor, like carbidopa or benseraside. So it's important to prescribe with peripheral decarboxylase inhibitor because we want the medicine, the levodopa, to reach the brain, to cross the blood-brain barrier, to exert the function where it's needed in the brain. So we also have dopamine agonists here, like pramipexole or ropinirole, where independent of the dopamine in the neuron, they directly bind to the dopamine receptor and exert this function. We also got drugs that can inhibit the enzyme that degrade the dopamine. For example, COM inhibitor like entacapone, opicapone, tolcapone, or the MAO-B inhibitor like selegiline or rasagiline. So when you inhibit the degradation of dopamine, more dopamine will be made available for its function. And we also have amantadine, not a common anti-Parkinsonian drug that we use. Usually we use for the dyskinesia in the levodopa-induced dyskinesia, but it has some mild anti-Parkinsonian effect. So the mechanism of action is stimulate the release of dopamine and also inhibit the reuptake of the dopamine. And independent of this pathway, we also got anticholinergic pathway, where they can block the action of ACH in the striatum, which can also confer some anti-Parkinsonian effect. So levodopa remain the most effective medication, but the drawback is in the later part of the treatment, the patient may develop motor fluctuation. We call it on-off phenomenon, where sometimes during the on, where the medication is working, so they have a symptom benefit with a reduction of bradykinesia and tremor, but off is when the symptom came back. So if you follow this one, this is the blood level of levodopa. At the early part of the disease, for example, this is a drug level of levodopa up and down if you take the medicine. You see this dark blue is the off time. If you see this white one, is the on time, the therapeutic window. And we see this light blue is the dyskinesia. So over the year, the on time will be getting less, the off time will be more, and the dyskinesia will increase. And sometimes we will have a delay on. Means normally if the patient take the levodopa, you only take about 30 minutes for the medication to be effective. But at the later part of the disease, you may take 1 hour or 2 hours for the medication to show its benefit. So we call it delay on or wearing off. So normally the medication can last you for, let's say, 6 hours, but at the later part of the disease may only last you for 3 hours or 2 hours. So we call it wearing off. So over the years, this is a typical scenario for the Parkinson's disease patient. So we have many drugs here, many colors. So I won't go into detail for this. And don't forget, we are not just treating the motor symptom. We also need to address the non-motor symptom. There are many non-motor symptoms, but I will just touch on the important one. Like for example, the REM sleep behavioral disorder just now, we can actually give them clonazepam. The benzodiazepine has been shown to inhibit the REM part of the sleep, or melatonin. So if patient have got constipation, we can give them some laxative like lactulose or bisacodyl. Or if they have some drooling of saliva, you may give them atropine sublingually or some botulinum toxin injection to the salivary gland. So there are also surgical therapy, for example, deep brain stimulation, where we insert the stimulator under the skin at the chest, just like the cardiac pacemaker, and the wire will be inserted into the typically subthalamic nucleus or STN or globus pallidus internus or GPI. So this device will actually give continuous electrical stimulation and have been shown to benefit the advanced Parkinson's disease patient greatly. So we also got apomorphine infusion. So they give a continuous infusion of apomorphine to the patient. And we also got subcutaneous apomorphine injection as a rescue treatment. For example, if you have a wearing off during unpredictable time of the day. And lastly, we also got jejunal L-DOPA infusion, also inserted straight into the jejunum to deliver the continuous levodopa. Okay, now I will show some video of the Parkinson's disease patient. So you can see, there's a left-sided resting tremor, upper limb and lower limb, very typical of Parkinson's disease. So in the outstretched hand, the movement actually improved and stop a while, and they come back again. So we call that re-emergent tremor, very typical of Parkinson's disease. And if the patient performs some action like finger nose test, the tremor get less. So on action, the tremor get less. So this is an example of the Parkinson's disease patient gait. You can see there is a very clear reduced arm swing on the left side. Over here, there's no shuffling, there's no stoop posture. The turning is okay. Maybe a bit slow here. So there's a testing for the bradykinesia. There are many ways. So you can see that the right side and the left side is very slow. There's a hesitancy. On the finger tapping test, the right side is normal. On the left side, very slow, very hesitant, very typical of Parkinson's disease. So the alternating hand movement, very slow on the left side. No problem with the finger nose test. This is my own patient in the clinic that I saw. This 60-year-old teacher, she has tremor for the past 5 years and has been treated as essential tremor. So she has been prescribed with propranolol with not much of benefit, gabapentin, topiramate, all did not help her. So when I saw her in clinic, this is her examination. So you can see clearly there is a right resting tremor.
Okay, can you stretch your hand forward, both hands?
The typical frequency for the Parkinson's disease, if you measure it, it will be around 4 to 6 hertz. So on the outstretched hand, initially there is no movement, but subsequently there's a re-emergent tremor on the right side.
Both hands like this.
On the wing beating position, no tremor, and the tremor come after a while.
Okay, can you do like this for the right hand? As big and
So
sparse.
on finger tapping, it looks okay here, but you need to compare to the other side. So here actually is slower.
Okay, like this.
The patient actually have a mild disease.
Like this. Okay, change hand.
So you can see the left side is very fast compared to the right side. So you see, when the patient do a finger tapping here, the tremor become worse on the right side. So on distraction, the tremor in Parkinson's disease increase. So in contrast to functional tremor, on distraction, the tremor get less.
Your nose and this pen.
So on finger nose test, it's all right. There's no problem.
Okay, right leg.
And we also can test the bradykinesia for the lower limb by toe tapping. On the right side is a bit slower compared to the left side. This is more smooth.
Okay, right leg.
Or foot tapping. A bit slow and hesitant compared to the left side. Yes, you can see more confidence here.
Cross your arm on your chest. Both arm. Stand up.
So there is no proximal
Okay,
myopathy.
can you put your arm down? And
So
walk
now we like to see the patient walking. So if you see, there's a reduce in the right arm swing. There's no shuffling, no stoop posture. As she walks longer, you can see the tremor start to appear. So one of the best way to bring out the tremor in a Parkinson's disease patient is to ask them to walk, and the tremor become very obvious. So this patient actually has idiopathic Parkinson's disease. We stop all the treatment and start patient on levodopa with great response. This young lady, about 28 years old, had this involuntary movement of the lower limb. You can see she cannot control it. So more over the lower limb. She also look a bit restless on the chair. There's not much of tremor. It's a bit slower on the right side. It's the gait. Not too bad. But she has some problem with turning, you see. The turning is a bit impaired. Another turning. So you see, it's some impairment in turning. So this lady, even though she's 20 years old, actually has a young onset Parkinson's disease. She had a Parkinson's disease at 19 years old. Her younger sister also had Parkinson's disease. She might have some genetic Parkinson's disease, but we couldn't send the test. And she was started on levodopa therapy, and now she developed the complication of the levodopa, which is a dyskinesia. This is a 58 years old gentleman with recurrent fall. So on walking seems all right, but there's a reduced arm swing bilaterally, more on the right side. Turning is a bit slow. He can do some tandem walking. He has a bradykinesia, he has rigidity. And why he has a recurrent fall? So I would like to test his posterior reflex by the pull test. If you observe, on pull test, he fell down like a log. So a normal person will have some compensatory mechanism to actually correct themselves when being pulled backward. So this patient has loss of posterior reflex, that's why he has a recurrent fall.
Ikut jari saya, tengok sebelah kanan.
So on the eye examination,
Kepala jangan gerak.
on looking to the right,
Sebelah kiri,
on looking to the left, seems to be okay. Some jerky, smooth pursuit can be seen. The smooth pursuit is not smooth.
okay, tengok atas.
But on the vertical
Kepala
gaze,
jangan gerak. Saya pegangkan.
on looking upward, the
Tengok
patient
atas.
cannot look up. There's a
Tengok
very
bawah.
much limited up gaze
Tengok bawah,
and down gaze.
tengok atas. Tengok bawah, tengok bawah. Okey. Sekarang tengok pen,
So on second
camera.
examination,
pen,
I asked the patient to look at the pen and to look at the camera to look for the saccades. So the saccade is usually one of the fastest reflex in the body.
camera.
So for this patient, you can
Pen.
see the saccade is
Camera.
slow
Pen, camera. Pen,
and there are some hypometria of the
pen.
eye.
camera.
You need two corrective saccade to
Pen.
look at the target.
Tengok pen, camera. Okey. Tengok pen atas, camera.
Vertical saccade is
Pen.
very slow,
Atas, tengok pen dekat atas. Tengok kamera.
very slow.
Okey. Tengok pen dekat bawah. Tengok pen dekat bawah. Kamera. Tengok pen dekat bawah. Tengok pen dekat bawah. Kamera. Tengok kamera. Okey.
So this patient,
Ikut jari saya.
this is the MRI of the patient. If you can focus on the brainstem part, there is a clear midbrain atrophy. This is the pons. He has some infarct in the pons. But look at the midbrain. It looks like a bird. There is a tapering end at the upper part of the midbrain. This is called hummingbird sign. This patient has progressive supranuclear palsy or PSP. He also been misdiagnosed as idiopathic Parkinson's disease. So it turned out that he has a PSP with poor response to levodopa and a very rapid progression of the disease with early falls. This is the last case.
Tangan ke depan macam ni.
So patient has some tremor. It's a bit jerky in quality.
Okey. Tangan kanan macam ni, laju-laju, besar-besar.
So on the finger tapping testing, he got a very severe bradykinesia, very slow, very hesitant,
Okey, sebelah sana sama.
decrement in the amplitude, bilaterally.
Laju-laju. Okey. Sekarang tangan ni sentuh hidung dan sentuh jari.
So on the finger nose test, it's clumsy, there's a intention tremor. So you can see that he has difficulty to touch his own nose. Some intentional tremor. So he has a bilateral cerebral syndrome as well.
Buat macam ni. Okey, tukar tangan.
So there's a dysdiadochokinesia on the right hand. Right is worse than the left side.
Tangan kat kepala. Boleh cakap perpustakaan.
Perpustakaan.
Persatuan Peladang-Peladang Pulau Pinang.
Persatuan Peladang Pulau Pinang.
So this is a typical speech of the cerebellar scanning speech or staccato speech. Each syllabus can be heard. So this patient have feature of Parkinsonism with bilateral cerebellar dysfunction. This is the gait, can see ataxic, broad base, sometimes fast, sometimes slow, sometimes freezing. There's a freezing of gait. Arm swing is reduced, turning is M block. He also have recurrent fall. So sometimes fast, sometimes slow. And these are eye examination.
Okay, ikut pen. Ke kanan, atas, bawah,
On looking to the right is all right.
tengah, atas, bawah, kiri,
On looking to the left is all right. Vertical also all right.
bawah. Okay, ikut saja pen saya.
On the smooth pursuit is kind of jerky in quality. It's kind of jerky.
Okay, sekarang ikut arahan saya.
Saccade examination.
Tengok pen, tengok kamera.
So you can see the eye have to do two corrective saccades. For example, if you ask the patient to look at the camera, the eye from the outer side will fall short from the midline before the eye correct again to go to the target. So we call it eyes hypometria.
Pen, camera. Pen, camera.
So you can see that very clear.
Pen,
eyes
camera.
hypometria, eyes
Pen,
hypometria.
camera. Pen,
These are
camera.
feature of
Okay.
Parkinson,
Pen,
especially
camera.
in the neurodegenerative disorder like
camera.
Parkinsonism
Pen,
or cerebellar
camera.
dysfunction.
Pen, camera. Pen, camera. Pen, camera. Tangan ke depan macam ni.
So this is the neuroimaging of the patient at the pons level. This is a cerebellum and this is a fourth ventricle. You can see the typical hot cross Banzai. So this one, the hyper intensity in the midline, and this part in the horizontal plane in the pons is called hot cross Banzai. This patient has multiple system atrophy, or we call it MSAC. C denotes the cerebellar subtype as the most predominant features. So this is the end of my talk. Thank you so much for your attention.
Thank you, Dr. Neo, for the very informative talk. This has definitely broadened our perspective on a career in neurology. And I think we can all agree that information regarding the management of Parkinson's disease was insightful. Due to time constraint, we have minimized the number of questions to which we want to highlight on. The remaining questions will be sent to Dr. Neo through WhatsApp and his answers will be shared later. Now, I would like to call upon Ms. Varsha to conduct the Q&A session.
Hi, Doctor. I'm Varsha here. So just a few questions we've compiled for you. So first question, does serotonin cause sleep problems in patients with Parkinson's disease?
Does serotonin cause sleep problem?
Yeah.
Yes, actually, sleep is a very complicated issue. So just now I say about REM sleep behavioral disorder, the pathology is actually in the brainstem. So when you have, in one of the paper where they call it about Bragg hypothesis, they say that the alpha synuclein actually travel from the brainstem and ascend up to the brain before it affect the other part of the corticals or the cortex, for example, the frontal lobe. So in the brainstem, we have the locus coeruleus, which is actually the site of production of the serotonin. So involvement of this part, the dopamine and the serotonin can actually affect the sleep.
Okay, so next question. Is there any development for a definitive cure in Parkinson's disease?
This is a very good question. There's been many talks that I attended recently virtually by the overseas consultant. In short answer, not yet. We don't have a cure yet for, not even a cure. We don't have any medicine that can actually retard the progression of the Parkinson disease as of yet. There's tried so many compounds, for example, a ginkgo biloba or even a tocotrienol or some if whether levodopa is actually protective for the Parkinson disease or even dopamine agonists like pramipexole or ropinirole. So far, none of the treatment has been found to actually retard the progression of Parkinson's disease. So in a recent year, people have been trying to actually identify the Parkinson's disease at the pre-motor stage, the one that I showed just now. Even 20 years before the Parkinson's disease, you already have constipation. 10 years before, you have a REM sleep behavioral disorder. So maybe we can detect this patient and treat at the pre-motor stage. Maybe actually they can respond better to our treatment, or maybe slow down the progression.
Okay, thank you, doctor. So next one, in your opinion, what are some improvements you would like to see in the future of neurology in terms of its practice or rehabilitation, etc.?
Future in neurology. I think just now I said that there's a high growth in the neurology field. So there are more and more treatment, more and more exciting new development in the pathophysiology of the disorder. More genetic has been found every day, and more drugs have been found. More antibodies have been found that can explain certain disorder that last time we don't have the diagnosis. And I just want to mention that from my own finding, I found out that from the Malacca Medical College, it's only 2 who take neurology subspecialty. It's only me and my batchmate named Dr. Prasad. So I would definitely encourage MMMC students to take up neurology subspecialty to progress the neurology in Malaysia.
Okay, there are a few questions left, but I think we'll forward it to you later because of shortage of time. So thank you so much, doctor. Okay, so I'll pass it back to you, Tharma.
Thank you, Varsha. Now I would like Ms. Kanchana to give the vote of thanks.
Hang on, Tharma, Prof. Nachi wants to say a few words, so we will. Prof. Nachi, please go ahead. Prof. Nachi, you have to unmute yourself. Okay. I think Prof. Nachi is not there, or what? He got disconnected. Tharma, you can carry on. Like, if he comes in, we'll address that later.
Okay, sir. Now I would like to ask Ms. Kanchana to give the vote of thanks.
Thank you, Tharma. First and foremost, on behalf of Student Council, we would like to express our gratitude to our speaker, Dr. Neo, for his time and this insightful talk. Next, we would like to thank Prof. Dr. Adi Negara, then Dean of Faculty of Medicine, for making time to attend this talk. Of course, a big thank you to Student Council members for their efforts into making this talk a success, along with the guidance from our advisor, Prof. Dr. Som, for ensuring the success of our talk. Thank you to all participants for attending this continuous medical education talk, and we hope to see everyone again in our upcoming sessions. Thank you.
Prof.
Thank
Nachi
you,
is
Prof.
here.
Thank you, Student Council.
Yes, Prof. Nachi wanted to say a few words. Please go ahead.
Okay, sorry, just now I went off the air for a while. No, this is a very interesting topic. I congratulate Dr. Neo, okay, and on his success and so on. No, this is because I was initially involved in the surgical treatment of Parkinson's Okay, we have progressed quite a lot. Somebody asked this question about treatment of Parkinson's, any cure? Unfortunately, no. Maybe in the late 70s, we started off with the radio frequency lesions, okay, in the subthalamic nucleus and so on, and we had some good results at that time. But subsequently, the whole surgical milieu changed to mostly deep brain stimulation. For example, we go to globus pallidus internus, and we have a deep brain stimulation there. You implant the electrode, and they got stimulation from stimulated, and is quite useful for dyskinesias.
Yes.
Pallidus internus. Whereas if you are choosing a subthalamic nucleus, maybe you can reduce the anti-Parkinson's medication. Okay, it helps. At the same time, if you got a gait disorders like freezing gait and so on, then you can get a pedunculopontine nucleus stimulation. It can happen. But as you said, if we still got intractable, then you can still do some pallidotomies, but it is not a cure. And we ask for anything happening new. What I understand is my colleagues from Oxford, who I worked with them before, they are trying to get some monoclonal antibodies, just like what we are doing for immunotherapy, targeted therapy, and so on. They are trying to find some sort of medication. So
yes,
we do not know. Maybe in a couple of years from now, we may get a better outcome. That's all I want to tell you. Thank you very much.
Thank you so much. There's been development in this anti-alpha synuclein.
Yes.
So yeah, one of the treatment.
Yes.
Thank you so much. All right, I think we can conclude our session here today. Thank you to all the participants and student council members for making this event a memorable one. Hope to see everyone in the upcoming CME talk.
Thank you, everyone.
Thank you.
Thank you. Thank you so much, Neo, for the lovely presentation.